Welcome to the Medical Imaging for All podcast, brought to you by Clarius Mobile Health. This show is dedicated to exploring the trends and technologies shaping the future of medical imaging. Here's your host, Ohad Arazi, CEO of Clarius Mobile Health. Now, let's jump right into today's episode.
Hello, everyone, and thank you for listening to another episode of our podcast, Medical Imaging for All. Today, I'm joined by Dr. Larry Istrail, who is a hospitalist physician, an entrepreneur, and an author. Larry has been covered by NPR and the Washington Post for various medical startups he's founded. He's the creator of an online educational site and is the author of the POCUS Manifesto, really one of the most seminal bodies of work on Point of Care Ultrasound. Larry, thank you for being with us today. Before we get any deeper, could you tell us a bit more about yourself?
Thanks so much for having me, Ohad. Like you said, I'm a physician in Northern Virginia. I am a hospitalist, so I treat patients who are admitted to the hospital for various reasons, non-surgical reasons like pneumonia, heart attacks, heart failure, cancers, things like that. And I've been doing it for about 5 years. Before that, I did 3 years of residency at the same hospital I'm at. And I really got into POCUS about 6 years ago when I saw one of my colleagues who was really good at POCUS at the time doing a full body head to toe exam and getting the answers to, the questions I had, which traditionally would take, 2 to 3 days and multiple CAT scans, echoes, things like that. And so that really kind of started me on this journey to see like how incredible POCUS is, how it really just gives you the superpower of looking inside people's bodies and seeing their organs function in real time, and just kind of trying to expand the field and get really good at it and see where that takes me.
Excellent. No, that's really exciting. And I certainly love speaking with physicians like yourselves that are both clinical and techie and geeky and passionate. Maybe just before that, what brought you into medicine, Larry? What was kind of the calling that you saw in this field?
Well, I used to be a big basketball player, and I went to this boarding school to play. It's called the Lawrenceville School, actually, between high school and college. So I was kind of that weird super senior. And in the Northeast U.S., it's quite common for athletes to take one extra year to get ready for college sports. And it was really there when I went to this basketball school that I started thinking about careers besides basketball, which is kind of ironic. But through like sports medicine and injuries, I kind of got interested in medicine, initially orthopedic surgery, which is the classic athlete story. But then I wasn't too intrigued by that. And I really liked the puzzle solving aspect of internal medicine and the kind of intellectual difficulty that they present and try to figure those out. So that's how I got into internal medicine. And POCUS really just kind of enhances that ability to solve those puzzles, which is why it's a nice fit, I think.
Mm-hmm. I used to work a lot with radiologists, and many of them would talk to me about that same puzzle element of their job, right? Of like, in radiology and similar, I think, with internal medicine, it's like something's wrong with the patient, but you don't know exactly what. It could be anything. And then you're this sleuth now that has to, paint a picture, this journey through the patient's body to really figure out what's happening. I think that's so intriguing relative to specialists that usually are, dependent on a referral pattern to know this is a sports medicine injury. There's something wrong with this patient's shoulder. It's a tear in the rotator cuff, and now you have to fix it. So I can definitely connect to what you're talking about, and I can really see maybe how that stimulated your interest in this kind of tricorder-like futuristic diagnostic tool to get a better input. How did you end up in Northern Virginia? Are you from the area, or you're from the Northeast, further north, I think, right?
Well, I grew up in Maryland, or I went to high school in Maryland. Lived in New Mexico before that. It's a long story, but I grew up in Rockville, Maryland, and then so I'm it's about 30 minutes from where I work now.
Okay.
So.
All right. So you're more of a local guy. I can also associate with what you talked about of having thinking about a career outside of athletics. I have my eldest son is a very serious basketball player, and I'm sure he's going to do great. But I also try to inspire him to think about what happens if you don't make it to the NBA.
Yes, I've heard that talk many times, and you're right. You're definitely right.
All right. Well, maybe let's double click a little bit on your interest in ultrasound. So you said you had a colleague, you were kind of inspired to see how he could take a patient head to toe. What's been the journey? I mean, as you started to become interested in it, how did you gain knowledge? Because I'd say that my sense is that medical education frameworks are still quite nascent in terms of their focus on ultrasound, especially for point of care practices.
Yeah, it's pretty much non-existent. Basically, once I got interested, I would just practice on my own. So I would, for example, wheel the ultrasound machine into a patient's room that had an echo, and let's say they had heart failure, so their heart muscle was really weak. I could just go in and say, okay, I know this patient has heart failure. Let me go see what it looks like. And that's really just how it started. It's just like trial and error, putting the probe on the patient's chest, not seeing what you're supposed to and trying to figure out why. And then occasionally you'll see a patient with a really simple heart to see and to find. And you're like, wow, that's what it looks like, And that's really just how it started, because it's getting better, but there's really no formal training and residency where you finish residency and you're good at it, or you're certified. That's not how it works, right? I mean, it's getting there, but right now it's kind of still the Wild West. There's some certification courses, one of which I took through the Society of Hospital Medicine. And that's incredibly good, but it takes a lot of internal motivation, intrinsic motivation to do that. No one's going to pay you for it. You have to do it, in your free time. So most people aren't willing to do that. It's also not cheap. That's really how it developed. And then you really get these episodes that Neelam Soni, who is the author of the kind of standard POCUS textbook, when I interviewed him for my book, he talked about the POCUS, the POKISS, POCUS, which is like your first experience with POCUS that when you really get it, like your first kiss. And so I started to have these every once in a while where the patient was admitted for X disease and, everyone was following the appropriate plan. And then all of a sudden you do a POCUS exam. You're like, hold on, this is the exact opposite of what we were saying. This is not pneumonia. This is heart failure. So every time you have one of those, you get like a little high. And then I'm like, wow, this is incredible. And on top of that, it's a skill that pretty much nobody else has. It's growing, but there's only a very few people in my hospital, which is a huge hospital, that are comfortable doing it. So all those things combined really kind of intrigued me and motivated me to write a book about it, and I'm doing research using POCUS. So that's really how it came to be.
Yeah, maybe let's unpack the book for a moment, because it's one thing to be a clinical expert and an evangelist for something, but you're still a young doctor at this point, kind of getting your chops, building your credibility in the organization. It's a very big time investment to sit down and write a book. What inspired you to do that? That's kind of a non-orthogonal view on kind of a standard career as you're coming up through residency into fellowship and into practice.
Yeah, so a couple of things. One was right when COVID hit, the first couple of months, whenever no one knew what was going on, our hospital, as many other hospitals, were focused, I think, appropriately on, protecting the clinicians. People were hesitant to go in the rooms, very, very early on in March and April. But what I noticed is no one was using a stethoscope. All of a sudden, they just decided to stop using that. And I was like, well, that's kind of a tacit, admission that maybe it wasn't helping very much to begin with. But people were still using a lot of ultrasound. And because I felt like it was giving much more information, especially for COVID. So I wrote an article that got published in Stat, the online magazine. And then it got published on Doximity. And I got like 200 comments from all sorts of clinicians. I'd say majority of which were very negative and critical of me and everything from, I'm a technologist, has no idea about medicine tradition, medicine is going in the dumps. Like, I'm afraid when I retire, these people are going to be taking care of me. Like crazy stuff. Like when I'm trying to just argue for a technology that has better accuracy than a stethoscope. Like So that was like the first eye opener. And then, as I was getting better at and more confident with my POCUS skills and interpretation, I just found like I was speaking a different language to all the other doctors I work with. Like I felt like it was traveling back in time. I have this cool new tool that nobody has ever seen, and I'm trying to explain to them, I saw beelines, they have this, they have that, and they're like, well, I listened to him, I didn't hear those things, so that's not true, like. So I just felt like these people were very hardworking and good people who want to do the best for the patient. They just had never, been exposed to what POCUS is and how accurate it can be for most conditions, especially cardiopulmonary. So I wanted to write like a short call to action manifesto to explain briefly the history and how it kind of, in my opinion, is just a transition from the auditory stethoscope exam into the visual exam, just like radio to TV. I feel like it's really the same thing.
Yeah, it's interesting that you talk about that call to action. I recently had a Dr. Chris Fox sit in the seat, and he talked to me about the POCUS revolution. Your book is called the POCUS Manifesto. So what is it about point of care ultrasound that evokes this sense of counterculture in healthcare, like a resistance, right, or a revolution? Like, why is it those terms that are appropriate for trying to bring this into the standard of care?
I think medicine is a kind of a fraternity of, traditionalists who are very proud of their work. And, there's a lot of history and a lot of things that don't change for 50 to 60 years, which is a really weird kind of juxtaposition, because you have like these unbelievable technologies, these new surgeries, these new medical devices. And then you have kind of these traditions we do from 1820 that haven't changed. And so I think it really strikes a chord when people say, why are we doing this? It doesn't make any sense. And nowadays, it's like, well, that's how they train. That's how they've been doing it for 30 years. And you're asking them to change. So, and then I think the accuracy of POCUS in general is another kind of shot in the heart of these people who, really want the tradition to stick and maybe are sad or disappointed that it's not going to happen.
Where do you see the biggest pockets of resistance? I've heard that at times radiology was concerned that this would kind of disintermediate the existing referral pattern from, generalist to radiologist. I've heard that certain specialty areas were more reticent because they had really optimized and were very good, felt they were very good at diagnosing using physical exam or palpations. What's been your experience in terms of those pockets of resistance that you've been working to win over?
I think generally the older clinicians are more resistant. I haven't had a lot of in-person people who in person don't understand or don't appreciate it. It's more they just haven't experienced it and they don't really have any concept of what I said. Like, okay, there's beelines and, this is definitely pulmonary edema based on the fact that it's 98% sensitive and specific or whatever it may be. It's just like a different language. It just doesn't register. And then, there's definitely radiology's concern because, the idea is that non-trained clinicians will be now interpreting ultrasounds, which is definitely a concern. They need to be trained. It's not a simple thing to do per se, but that's true for everything. I mean, non-trained clinicians are listening with their stethoscope and then ordering a bunch of tests that shouldn't be ordered, but nobody seems to care about that. There's no way we're independently determining if what you hear on your stethoscope is true or not, or accurate. So I think there's a lot of that. I think there's also a lot of lack of awareness of how bad some of our gold standard of care tests are now. We just learn them in med school and we just assume that they're very accurate, which usually they're not.
You mentioned a few times this notion of education and training. Is that really the key to helping to continue to bear the torch of this revolution, to have education start earlier, younger generations of physicians coming out of med school, coming out of residency, coming out of fellowship, being trained in ultrasound?
For sure. I mean, I think there's a huge gap between people who want to be good at it and people who actually spend the time to do it. And part of that is just, a busy clinician with a family and a full-time job, they have a hard time learning a new skill. So yes, definitely if it's integrated into medical school, PA school, other school curriculum, then that is really what is needed, especially nowadays with the dramatic reduction in cost with companies like yours or Butterfly or others where, the cost is 10, 20 times cheaper than a giant wheeling machine, and you can carry it in your pocket. So, I mean, in this day and age, we really are living in the Star Trek reality from the 60s where with the tricorder. I mean, in my book, I found one of the clips from, the 60s, and it's just like incredible. What they're saying is exactly what we do right now. It's just really cool.
In our journey as a handheld ultrasound company, I'd say one area that we had to gain a lot of trust and confidence with the clinicians is around image quality. Because maybe when this domain started, it was easy to kind of say, well, it's a toy. It's not really good enough to be able to see. And therefore, if it's not good enough, I don't want to use it. I would prefer to refer to radiology because I don't have the time, the skills. It's not a good enough product. And I'm worried about liability. Do you think that's changed? Or what advice would you have to us as an industry on where we can focus to help win over the clinicians that, are maybe on the cusp there and now need to kind of go the last mile, take the plunge, learn the time, and allocate the time to learn this?
Well, definitely image quality is a concern, and there's trade-offs like the giant echo machines that the echo techs wheel around have amazing image quality, but they're giant machines and they need to take the elevator to go up a flight of stairs. So, as you shrink it, of course, there are some limitations, but it should be, sufficient to be able to see what you're looking for. I mean, so on lung ultrasound, if you can't see the B lines accurately or the lung, then, I mean, you're not going to be able to use it very much. Same with the heart. Like from what I've seen with Clarius and from Butterfly, when I compare my Butterfly, for example, to the Sonosite, which we have at the hospital, there's just trade-offs. The Sonosite generally for heart gives better images for sure. It has more capabilities with the Doppler and everything. But for lung, I'd say they're very similar, and for heart in a lot of the patients, most of who are thinner, you can get all the information you need for the most part. So I think, with you guys' wireless and portable and, depending on how long the battery lasts, I think it's clearly one of the devices for the future clinician. I just don't see how it's not.
What role, Larry, do you think that AI could help in obtaining a better image? My background before Clarius is I was CEO of an imaging AI company in radiology, so focusing on X-ray, CT, and mammography, where AI is principally used to triage or to interpret the exams. In ultrasound, a lot of, at least my company's focus has been on using AI more as a workflow tool to acquire more on the acquisition than on the interpretation, to help novice users kind of lower that barrier for entry, lower the threshold for being able to acquire a good image, either by, automating the gain or the depth of field, or segmenting the anatomy, placing the calipers, or even helping to guide the positioning of the probe. Do you think that AI could be one of those unlocking technologies to help overcome that education barrier?
I mean, yeah, I think learning by doing is really the best way, at least for me. Like I was saying earlier, just putting the probe on the patient's chest and with having no idea what you're doing, and just like, can you find the heart at all? It sounds easy, but in some patients with their big lungs or how they're positioned, you can put the probe right where the heart is and you don't see anything. So, to have an AI system that's kind of an assistant there for you to say, move the probe left, rotate right, tilt up, or even to say, okay, this is a good quality image, or this is not a good quality image. I think those would be huge if it was seamless and worked well for education. That would be huge. I mean, also, I think just for real-time calculations, like if you obviously ejection fraction or the strength of the heart is a big one. But if you put the probe on and you get a good image, ideally the machine should be able to calculate the size of the chambers while you're there and not having to do it yourself. Or you get the Doppler waveform, it should be able to calculate it for you, but
And maybe that could compensate also for an imperfect image. If it's not image-based, like you could imagine a world where a GP is doing, just kind of painting a picture across the patient's heart, doing 4 lines, and then automatically the AI, even without optimizing the view for that physician on the image, can do an accurate calculation of the B lines, measure the degree of interstitial lung fluid, and then help inform a decision on the congestive heart failure and the titration that should be applied, right? So I think that, in addition to helping to guide the acquisition of a better image, your point around the measurement and the calculation could be extremely valuable, again, as a means of lowering that hurdle rate. And I can really connect with what you talk about, where like the best way to learn is by doing. I mean, I certainly think about that way. I have younger children. I watch how they work with technology, right? I mean, that my kids who are teenagers have never seen a manual. They would never even think of downloading one. They never think they have to do a course on doing something. They'll pick it up and try to use. And if they get stuck, they'll open up a YouTube video that helps maybe guide them in real time on whatever it is they're doing. And I think that is part of how we should think about education, right? Could we have more AI that maybe automatically shows the texture of the anatomy, helps to segment it, even non-clinically, non-real time, but rather as a means to help train them? Because often these physicians know what the anatomy should look like in the textbook. They're just not used to seeing it in grayscale with this grainy ultrasound image.
I think that would be amazing.
And so maybe we've kind of established where point of care ultrasound is today. Obviously, you think a lot about this space. Maybe we can take a few moments to explore where will this go. And one thing that's been on my mind has been, will we see the intended user continue to evolve? Already, I think you mentioned PAs. We believe that PAs, physician assistants, nurse practitioners, nurses in general are really key to unlocking some of the bottleneck and challenges that exist in healthcare today, where so much is centered around the doctor and so much is centered around the hospital. Could we move it to other stakeholders and other care settings? Where else could that go as you look ahead to ultrasound?
The way I see it is now, after doing it for a little while, is like when I was writing the book, there was a few themes that I kept coming over and over. And one of them that applies more broadly, I think, is that like the innovation of the time, whatever it may be, 1800, 1700, or today, is really limited by the available technology, right? I mean, in 1800, there was no internet, there was no anything. And so René Laennec, all he had was a wooden tube. But that was huge. That was revolutionary. But, I feel like every few decades or a few years, whatever it may be, that foundation needs to be reassessed. Like, all right, we have a bunch of new technologies now. Should we reevaluate the physical exam with the current constructs of or limitations of technology? And I think the answer is definitely yes. So, I think it's about like reevaluating, reexamining everything that we even have a concept of as a physical exam. Like, what does it even mean to do a physical exam? I think with in a big, broader sense with POCUS, I think it should be, all right, if you go to the doctor with a rash, they should look at your rash. I think most people would agree. Look at it, not just take your word for it. So that's kind of inspection, right? Inspection of the skin. If you have pain in your wrist, they should palpate it, inspect it. But what if you have chest pain? Like right now, they just listen to it and then send you to get some testing. But why don't you just look at it? The point of care ultrasound, the name, I feel like is, I don't know, it's a good name, but it's not the best name, I think. I think a better name for appealing to people who don't know what it is is internal organ inspection, because that's all you're doing. All the pushback I was getting, I felt like, was just for people who had no idea what it was. They're like, oh, you send the patient to a radiologist to do your physical exam? No, that's not what it is. You're just literally looking at the organ. I mean, all of medicine really is before now is really like trying to infer what's going on inside of the person's body by manifestations, whether it's symptoms or signs on the skin or whatever it may be. But now you can literally look. So, so that's how we should think about it. And that's how we should try to recreate what the physical exam is. So, I did one study, I'm doing another one now, where I just felt like we have so much accuracy and precision at our fingertips now. We just need to prove that it's really easy to do, and you can do it very quickly at the bedside and get highly accurate results. So I think with that like framework, that's what the future should be. It's like you can figure out exactly what's going on if you know how to do it.
And then how does that impact the new stakeholders, new users adopting these types of technology?
Well, I think one, it's super exciting for them and motivating to know that, okay, like when I was training, and that wasn't that long ago at all, but you have a patient in clinic with chest pain, or let's say shortness of breath or cough. I mean, it could be anything from, a mild cold to lung cancer or, horrible heart failure. And you really don't know. I mean, the physical exam has huge limitations, and the patient's obese. There's just, it's really hard to do a good exam. And even if you do a perfect exam, the exam itself is just limited. So, what it comes down to is just a bad experience for the patient and the clinician, because you have to say, okay, well, I need you to get a chest x-ray. I need to order these labs. They won't be done for, a day or two. You have to drive to this place, get an x-ray done, make another appointment to come see me, and we'll discuss the results. I mean, that's like at least 3-4 days of wasted time and effort and people missing work. And it's just horrible for everybody. Whereas if you have an ultrasound in your hand, you can literally just look and figure it out in a second, in a couple minutes. And if you know the limitations and strength of POCUS, just like you should know it for chest x-ray, just like you should know it for the stethoscope, then you can be very confident in what you find or what you ruled out. So it just creates a whole different experience for the patient and the doctor, where they're like, whoa, how did you figure that out so quick? And the doctor's like, this is pretty cool,
Mm-hmm.
So it happens over and over now with my patients, and they're just like, wait, you can look at it on your phone, and they're like, wait, you have the answer in 2 minutes. So it's just, I think that is what motivates people to like go into medicine nowadays, I think.
Do you see, Larry, opportunities for point of care ultrasound or handheld ultrasound to even span ultimately into the patient's home, maybe for monitoring a critical condition? Again, I'm not envisioning a world where a patient self-diagnosis. I think that the regulator would take a very strong stand against that, rightfully. But what about for monitoring? And again, maybe some of the things we talked about, like using AI to quantify and eliminate operator variability in order to provide another input once a diagnosis has been made. Do you see that happening?
It's interesting. Yeah. I mean, there was a study recently, I think it was, I'm not sure if it was the Butterfly Company or another one, but they gave probes to heart failure patients, and then they sent them home with them, and they would scan their own lungs. And, they were taught how to do it briefly. They'd scan their own lungs, and then the images would be reviewed by someone. And they showed that the patients was able to, get an accurate, acceptable view of the lung and appropriately document how many B lines were there. So something like that with lung ultrasound, I'd say is really easy compared to cardiac, but something like that I find interesting. But yeah, I mean, if it's a very focused question and a really simple thing to do, then yeah, the patient, maybe they could, scan their pneumonia every day, see if it's getting small or something like that. But it's tricky. I don't know. There's a lot of limitations, and so I don't know about. I'd be skeptical outside of a very limited, like, is there B lines or not?
Mm-hmm. We've seen some of those use cases evolve in obstetrics, and actually we were involved, are still involved in a clinical trial in the fertility space where patients are doing a vaginal exam, and being overread remotely or guided remotely by a sonographer to do an antral follicle count, which is, again, actually relatively easy to see and has a very important kind of impact just to the patient's comfort, because fertility exams are invasive and they have to be done daily during the ovulation cycles for women that are trying to get pregnant through IVF. So that's just an interesting evolution. And again, maybe it won't be in things as critical or as chronic as lung or cardiac conditions, which could be tougher, but maybe other areas that are, that have to do with obstetrics, gynecology, or even in orthopedics. So yeah, interesting to get your perspective. And it's certainly an area that we're thinking about, but still, as partners of yours and others in this revolution, still a lot of road ahead of us. Even before we get there, still a lot of clinicians still to win over and help them be successful with what they do.
I think OB, that's an interesting case. I haven't heard of that one, but also like just home monitoring of fetal heartbeat. Like right now, I don't know what the numbers is, but there's a huge number of people who go to the OB emergency departments just because they don't feel the baby moving, and they could be completely fine. The amount of, psychological stress that causes on a mom if she has. So if you could just quickly look and see a moving heartbeat. I mean, I've had two clinician colleagues who've asked to borrow my probe because they were, for the exact reason. They were pregnant, they didn't feel the baby moving. And so I lent one to them and they would use it, once a week or so. So something like that is, I think, very clear, like yes or no answer use case would be very good.
Yeah, I saw a study from Clalit Healthcare in Israel where their data was that 26% of all ER visits during pregnancies were false alarms. And having 3 kids, I know what it's like. My wife says, honey, I haven't felt the baby kick. Should we go get an ultrasound to just see that everything's okay? And that could be a real quick look. Maybe somewhere where the regulator would feel, the risk is quite limited. It's providing more of a binary closed loop indication. Yes, no fetal heart rate or placental fluid or whatever else it can cover in that. And maybe even not an image-based analysis, but more of a quantitative one that's just done once you've acquired a good enough image. So I'd be keen to see where that goes. We'd certainly think a lot about these use cases emerge.
I mean, even the OB follow-up appointments, a lot of them were just, you go in and they just, basically use a stethoscope or which is a audible Doppler to listen for the heart. And in my case, when we had our kids, we had already looked at the ultrasound, of course, but like why, it just makes you kind of wonder, why not just do the ultrasound if you can have a handheld one?
Well, Larry, we've covered a lot of ground today, starting with your roots as an athlete, what drove you into medicine, your interest in ultrasound, and this really exciting journey you've been on at kind of the tip of the spear of the revolution. And I know that your book, the POCUS Manifesto, has inspired many, and still many to come. We certainly view ourselves as partners in this journey. And thanks for talking us through some of the use cases and some of the things we have to do as a collective industry to win over more physicians, to address education and make it easier to use. And also appreciate your thoughts on some of where could this go in monitoring chronic conditions and generally in breaking out of the 4 walls of the hospital. I really enjoyed our talk. I learned a lot today. So thank you for taking the time to speak with me.
Thank you. It was a lot of fun. I'm excited to see what you guys can come up with.
And Larry, if our listeners want to learn more about you and your work, where should they go? Where can they find more information?
The best places would be POCUSMedEd.com, which has a lot of good educational info and a blog that's updated with interesting cases or topics in POCUS. Or you could go to the POCUSManifesto.com, or you could get it on Amazon.
Excellent. I encourage our listeners to do that. And then to all of our audience, as always, we appreciate the time together, and be sure to catch us on the next episode of our podcast. That's a wrap.
Thanks for listening to the Medical Imaging for All podcast, brought to you by Clarius. If you enjoyed today's show, Please do us a favor and leave us a review on Apple Podcast or Spotify. For the latest episodes, please visit www.clarius.com or search Medical Imaging for All on your podcast platform of choice. Thanks again, and we'll catch you on the next episode.